this case report and invited me to speak to you. As you can see, I'm a general surgeon working in Estonia with a specialty for colorectal cancer. And how I find these patients is that they turn to me because they think they might have a hernia. But in many cases, I find endometriosis. So with a little bit of background, why we are talking about endometriosis, it is not very often seen, but the incidence for endometriosis in abdominal surgery scar is up to 1% of women undergoing pelvic surgery, uterus surgery mainly. Wound endometriosis often goes without symptoms, but there can be palpable mass which can be mixed diagnosed with hernia. So they come to general surgeon. And usually the mass is painful during menstruation, and also it can bleed itself. So malignant transformation for endometrioid lump is very rare. But if the endometrioid lump starts to grow, we have to keep in mind. Then transformation for premenopausal females is about 1%, and postmenopausal is a little bit higher. So all the patients I found from literature had some kind of uterine surgery before, mainly caesarean section. The median time from the initial surgery for development of endometrioid cancer is about 19 years. So you can see it's very, very big time. And the most frequent histological type was clear cell carcinoma. Most of the patients were treated by extensive surgery and or chemo or radiation therapy. The overall survival is not so good, and the medium survival is about 42 months. So going back to a case I was treated, the patient was a 54 years old woman who had 30 years ago appendectomy, which didn't go very well because it complicated ureter and bladder injury, and that's why cystectomy was performed with bilateral ureterosigmoidomy. 20 years ago, she had cesarean section without any complications. And I found also that already 10 years ago, the gynecologist diagnosed the caesarean wound endometriosis. But the patient wasn't bothered with that a lot. And she used oral contraceptives, and the pain was very mild. That's why they didn't treat it any other way. When the patient reached menopause at the age of 52, she noticed that increased the mass from the lower abdomen. So when I saw the patient, that was the picture that I saw. So below the umbilicus area, there was a bleeding ulcer about 3 centimeters in diameter, and around it, this was a big inflammatory mass which was not movable. So, and the gynecologist evaluation was normal. So my initial thought was that that's not usually the wound endometriosis I have seen, that it can be malignant process. So we did CT scan and MRI. And also with the CT scan, you can see on the picture, there is a big mass on the lower abdomen, up to 10 centimeters in diameter. And the heterogeneously contrasting tumor has malignant signs. And to see the evaluation, to evaluate the borders of the mass and other structures, we did MRI also. This is sagittal view of the MRI, which shows the involvement of the lower abdomen wall and also uterus, small intestine, and sigmoid colon loop is involved with a mass. And all that investigations clinically and radiologists was confirmed that it is a malignant process. But the biopsy confirmed it for histology, that it was clear cell carcinoma arising from the caesarean wound endometriosis. The case was discussed with multidisciplinary consortium where neoadjuvant chemotherapy with a combination of carboplatin and paclitaxel was decided to be the best option to reduce the volume of the tumor before the surgery. But unfortunately, she received about 3 courses of neoadjuvant therapy, and planned CT scan was performed, and unfortunately it showed the enlargement of the tumor, so the progression was confirmed, and that's why the chemotherapy was switched to palliative therapy. But during the palliative chemotherapy, the patient got the intercutaneous fistula with a small bowel defect. And that was a very crucial moment for the patient because it has a significant effect on quality of life for the patient. As you can see from the picture, there was no possible to put the stoma bag on that defect, and the wound was inflamed all the time. That's why the decision for the surgical treatment was made. And next, the surgical operation meant for us that all the rectal muscles from below abdominal and with small bowel loop, part of sigmoid colon, uterus and nexa was all en bloc removed. And as you can see, the defect is quite large and we couldn't close it simply. That's why I used biological mesh permacol to cover the bowels. We had no fascia there. And then the result, this is the specimen we removed from the patient. And then the result is there. And on the left picture, there is a right after the operation, the picture. And on the right side, it's a year after the operation. So you can see she healed very well. The specimen weighed almost 1 kilogram, and based on morphological and immunohistochemical examination, it was clear cell carcinoma, which originated from endometriosis of the anterior abdominal wall. Cut lines were intact, and unfortunately, one regional lymph node was positive. So another multidisciplinary team meeting was performed, and the decision for adjuvant systemic therapy was made. She received adjuvant therapy, and for now she is relapse-free 2 years after the operation. And she works as a teacher and rates her quality of life very good. So during this discussion, we saw that the management for endometrioid cancer is very controversial because it's very rare and there are no specific guidelines to treat that. And mostly I found from the literature that oncologists follow the guidelines for ovarian cancer. So did our oncologist also. Endometriosis-related cancer is very rare and associated with poor prognosis, with overall 5-year survival rate about 40%. Treatment with multidisciplinary team is very important to achieve the best outcome. It is also reported that we need some more long-term results to come up with optimal treatment and guidelines for this kind of disease. The main treatment still is surgical, and the goal is to wide and complete the excision of structures affected by the tumor to get the clean, healthy margins that can prevent recurrence rate. And also, it is reported that most of the times plastic surgeons are needed to reconstruct the abdominal wall. The adjuvant radiotherapy and chemotherapy also has been reported, but there are different protocols and no, like I said, no strict guidelines yet developed. However, in the literature also I found that chemotherapy based on combination of carboplatin and paclitaxel has been mostly described. So why are we talking about that? Why is it so important when we see that very rarely? I think mostly because caesarean section is the most common surgical procedure associated with abdominal wall endometriosis. And it is also appears to be the most common operation described for cancer cases associated with wound-related endometriosis. Since caesarean section worldwide increases, we have to accept increased number of cancers arising from endometriosis also. That's why we are talking about it. What we already know is drug treatment for scar endometriosis is usually ineffective. So surgical removal is recommended to confirm the diagnosis of endometriosis, and that's why prevent malignancy. The patients often come to me also as a general surgeon to remove the lump. What we have seen that gynecologists sometimes remove it, sometimes don't remove it, and it depends on the symptoms of the patients. But with this case, we learned that if endometriosis gets cancerous, it is very hard to treat, and has a very poor prognosis. That's why I would recommend to remove all the time wound endometriosis. What are the teaching points from this case? I think looking back with this patient, she was going to the doctors very regularly, and also with gynecologist who diagnosed already 10 years ago caesarean section scar endometriosis, and there was no treatment with drug treatment for that, but the surgical treatment was not offered for the patient. I think maybe the delay in surgical removal led to malignancy of the endometriosis, and which needed that extensive surgery also. If it would have been done earlier, maybe the patient wouldn't get cancer disease. So in conclusion, since the incidence of caesarean section rate is rising, we should expect to have an increased number of wound endometriosis and also the number of endometriosis-associated cancer rates. Endometriosis-associated abdominal wall cancer is very rare and aggressive disease and has a poor prognosis, and is mostly diagnosed after caesarean section up to 20 years. The most frequent histological type is clear cell carcinoma, And the treatment usually involves radical surgery with adjuvant chemotherapy or radiotherapy. The literature doesn't recommend neoadjuvant chemotherapy because it has no significant benefits, as well we saw in our case. But of course, there is some chance that it will react and decrease the size of the tumor. These are the references, and I thank you very much. This is my hospital, East Tallinn Central Hospital from Estonia, where I'm currently. Thank you very much. Do you have some?
I am joining from Turkey. Today I will tell you about physiotherapy approaches in the management of urinary incontinence during pregnancy. Incontinence is a condition characterized by the involuntary loss of urine or feces, diet dysfunction or weakening of the bladder or sphincter muscles. It typically occurs as a result of impaired bladder control, with urinary incontinence being the most common form, involving the unintentional leakage of urine. Urinary incontinence is frequently observed in women postpartum and is also associated with vaginal delivery. Secretly, the pelvic floor muscles before childbirth offers protection against urinary incontinence. Urinary incontinence affects approximately 21 to 45% of pregnant women. Is more common during the second and third trimesters, particularly during coughing or sinusing. Pelvic floor disorders are common during pregnancy, postpartum, postmenopause, and aging. Conservative treatment should be prioritized and surgical techniques should be considered only when necessary. Preventive measures for pelvic floor dysfunction are recommended during pregnancy and postpartum. Physiotherapy interventions, particularly pelvic floor muscle training, are applied as part of conservative treatment to address this condition that negatively impacts women's quality of life. These interventions also included electrical stimulation and perineal massage. Conservative treatments such as lifestyle modifications, patient education, pelvic floor muscles training, biofeedback, bladder training, functional electric stimulation, and extracorporeal magnetic innervation are used as first-line therapies for urinary incontinence. These methods are known to be safe, cost-effective, and accessible. Urinary incontinence may result from hormonal and physical changes associated with the childbirth and is also linked to perineal trauma. Physiotherapy approaches such as pelvic floor muscles training not only reduce urinary incontinence symptoms, it also positively influence parameters such as muscle strength, endurance, and quality of life. Pregnancy pilots combined with childbirth education helps reduce stress and urge urinary incontinence. This approach also reduces excess weight gain, increases vaginal delivery rates, shortens labor duration. Urinary incontinence may cause depression. Early treatment and support are important. Now I will talk about the recent literature on this topic. Santos et al. Study işte others study object method findings. Study object to investigate the effectives of aerobic and or resistance exercise combined with pelvic floor muscle training in preventing and training urinary incontinence during pregnancy. Method systematic review. Findings group exercise combined with pelvic floor muscle training were found to be effective in preventing and managing urinary incontinence. Lee and Lee study object to examine the effects of pelvic floor muscle training combined with infrared physiotherapy on postpartum UA. Method clinical intervention study. Findings combined therapy significantly improved pelvic floor strength and quality of life. Zhang et al. Study object to assess the impact of prenatal exercise on UI during late pregnancy and at 3 months postpartum. Method randomized control 3. Findings prenatal exercise reduced UA in late pregnancy and the postpartum period. French et al. Study object to investigate the role of serotonin and ILT then in urinary problems in women with gestational diabetes. Method molecular biological analysis. Findings serotonin and IL-10 may play a predictive role by regulating blood and urine viscosity. Fernandez et al. Study object to compare pelvic floor muscle training with and without biofeedback in managing UA during pregnancy. Method Cochrane systematic review. Findings pelvic floor muscle training was effective. Biofeedback provided no additional benefit. Alioni study objective to evaluate the effective pelvic floor muscular training, biofeedback, and electrostimulation in the treatment UA. Method systematic review. Pelvic floor muscular training was the most effective method. Biofeedback and vaginal cones were also effective, but less so than pelvic floor muscular training. Lauper et al. Study objective to analyze the effects of whole body vibration exercise on pelvic floor muscle activation. Method muscle activity measurement. Findings highest pelvic floor activation was observed at vibration frequencies between 6 to 12 Hz. Conclusion. In conclusion, UI is a condition that commonly affects women during pregnancy and the postpartum period. Prevention and disease management are important in its treatment. In this context, surgical and conservative approaches are used. Physiotherapy plays a critical role among conservative methods. Specific exercise recommended during and after pregnancy can help prevent and treat UI. Although is no universally accepted protocol for this exercise, adopting an individualized approach for each patient significantly enhances treatment outcomes. Reference. Thank you.
Has challenged collaboration between cardiologists and obstetricians. Peripartum cardiomyopathy is an idiopathic cardiomyopathy presented in the last trimester during pregnancy or few months after the delivery. During pregnancy, heart failure was first identified in 18th century by Richter. It was described as cardiomyopathy in 1930. But according to the last guidelines of European Society of Cardiology, peripartum cardiomyopathy presents with heart failure secondary to left ventricular systolic dysfunction toward the end of the pregnancy, and in the months following delivery, the majority diagnosed postpartum. Really, the true incidence is unknown. The higher prevalence of peripartum cardiomyopathy is in Haiti, in Africa, and Black women in other countries. Variable prevalence across countries and ethnic group is different. The incidence of increase with age, maximum of 40, 54 years in age, African ethnicity, multiparity, twin pregnancy due to fertility, smoking, diabetes, preeclampsia, and pregnancy hypertension. Mechanism of pathogenesis are not clear. Commit to hit models including genetic predisposition and systemic angiobalance, and it's thought to be crucial. The impaired vascular and metabolic function may be central to the development of peripartum cardiomyopathy. The potential etiologies to development of peripartum cardiomyopathy are high levels of damaged vasculature, which is being implicated in the pathogenesis of preeclampsia. They're suggesting an overlap between this condition. Genetic studies in peripartum cardiomyopathy have related genetic similarity with dilated cardiomyopathy. Real cause is uncentered, but potential etiologies include inflammation, angiogenic imbalance, and vascular damage. What are the risk factors for pericardium cardiomyopathy? Risk factors are in three groups: before pregnancy, high blood pressure, hypertension, diabetes, obesity, selenium and zinc deficiency, and substance use disaster. Risk factor to pregnancy: being pregnant for the first time, being pregnant with twins or triples, having a prior diagnosis of peripartum cardiomyopathy, using IVF, and complication during postpartum, preeclampsia, anemia, thyroid disease, asthma, or other autoimmune disease, and using Tocalise for a long time. During pregnancy, blood volume increased about 40% and cardiac output too. Progesterone and estrogen increase influence the cardiovascular system. On the other hand, hypercoagulability state is the rise of coagulation factors and reduction in the fibrinolytic activity. During labor, the stroke volume increase to anxiety and pain, and venous return from the uterine contraction. After delivery, the increased output, it's about transfusion and decomposition of inferior cava vein. The understanding of the pathogenic mechanism is very necessary. The physiological cardiovascular change mediates the development of peripartum cardiomyopathy in predisposed women. They are exposed to high risk of cardiac function deterioration, heart failure, arrhythmias, thromboembolic events despite medical treatment. Diagnosis is often delayed as symptoms are similar with normal pregnancy. Peripartum cardiomyopathy is common in first postpartum month and rare before after 36 weeks. But presenting symptoms are different. Fatigue, decreased exercise tolerance, dyspnea, orthopnea, tachypnea. Blood pressure in some times is normal or in other times is low due to low cardiac output. Signs of heart failure are not rare, and sometimes with symptoms of neurologic vascular events. What tests will be done to diagnosis? Normally, ECG does not rule out peripartum cardiomyopathy. ECG may show non-specific ST abnormalities, low voltage, tachycardia, bradycardia, arrhythmias, or left brain branch block. But chest X-ray show pulmonary venous congestion, pulmonary edema, bilateral pleural effusion, cardiomegaly, or in sometimes it just be normal. Levels of BNP and terminal pro-BNP are usually marked elevated, but echocardiography is safe to use during pregnancy. MRI, it's better not to use. Diagnosis for the first time by echocardiography is not rare, but its value when we meet this criteria, ejection fraction is low, left and right dilatation or dysfunction, functional mitral or tricuspid regurgitation, pulmonary hypertension, left atrium and right atrium enlargement, intracardiac thrombosis may occur in left ventricular apex. Pericardium cardiomyopathy is difficult to make differential diagnosis with dilated cardiomyopathy, valvular disease, congenital disease, Takotsubo, myocarditis, pulmonary embolysis, pulmonary edema from severe preeclampsia or prolonged tocolysis, or amniotic fluid embolism. And sometimes it's very difficult to make differential diagnosis. Management of peripartum cardiomyopathy is to be the same with patients with heart failure with reduced ejection fraction. The management of heart failure during pregnancy need to careful to ensure fetal safety by consulting cardiologists and obstetrician together. Every patient that complicated with acute severe heart failure should be transferred in issue O. Management of peripartum cardiomyopathy is different in every patient, but bronchoptine, oral heart failure, anticoagulation, relaxant, and diuretic, of course, can use. But the specific in medical therapy we can discuss, it must be considered to avoid fetotoxic agent like ACA inhibitor or ARB inhibitor, mineral corticoid antagonist, and sure atenolol. Tube diuretic and thiazides should be avoided in the absence of pulmonary congestion. Furosemide and hydrochlorothiazide are most used, but lower fetal birth weight has been documented and should be monitored. Beta blockers, like calcium blockers and calcium blockers, may use safe, and the best of them is metoprolol. Hydralazine and nitrites can use in case of hypertension. And dopamine can use if inotropic drugs are needed. The use of bromocriptine, based in the last guideline of European Society of Cardiology, it's necessary to use bromocriptine. In this case, bromocriptine, we know, is a dopamine antagonist and inhibits the release of prolactin. Due to the association with thrombotic complication, therapeutic anticoagulation is recommended in conjunction with bromocriptine. It originally marked for lactation suppression, and the patients have to beware for the implication of breastfeeding when use bromocriptine. Anticoagulation in peripartum cardiomyopathy is very important. It's very important because patients with very low ejection fraction and prophylactic anticoagulation should be considered during pregnancy, and 6 or 8 weeks postpartum. Warfarin across the placenta as low molecular weight heparin does not cross the placenta and can be used. But the anticoagulation, of course, can use, but European Association of Cardiology used when ejection fraction is less than 30%, whereas American Association Cardiology suggested use when ejection fraction is less than 30%. But the novel anticoagulation are not best suited, and in pregnancy and lactation, it's better to avoid. Cardiac transplantation, of course, it made when mechanical circulatory support is not possible, and when do not recover after about 1 year. Higher rates of graft failure and death after heart transplantation. All immunosuppressive enter the fetal circulation, and despite successful pregnancy support cardiac transplantation, International Society of Heart and Lung Transplantation recommended against breastfeeding. The clinical outcome is diverse from complete recovery to death. We can see brain injury, mechanical circulatory support, cardiac transplantation, thromboembolic complication, pulmonary edema, cardiopulmonary arrest, and which is the worst, death. Predictors of major adverse events are different, but ejection fraction at the time of diagnosis is the most reliable predictor of the adverse events on long-term recovery. Mortality estimated differently. Prospective large cohort studies have focused on 6-month outcomes, supporting a mortality range from 2% in Germany, about 12% in South Africa, and 24% in 2 years in Turkey. But peripartum cardiomyopathy may be associated with mortality or severe and lasting morbidity. Mortality rates is about 10% in 2 years and about 30% in 3 years. But mortality is caused by progressive heart failure, sudden death, and thrombolytic events. Peripartum cardiomyopathy has a higher rate of recovery. It's a good news, and it's better in peripartum cardiomyopathy than other cardiomyopathy. Mode of delivery, it should be discussed with cardiologists, obstetrician, anesthesists, and neonatologists, and urgent SCS irrespective of weeks in advanced heart failure or in case with hemodynamic instability is present. After management, the management after delivery is very important, depending on the clinical status and myocardial function. The fluid overload risk by increased venous return and must be managed very carefully. Neurohormonal blockade with ACE, R, and antagonist or aldosterone. The diuretic to reduce preload, vasodilators to increase the cardiac output and decrease vascular resistance, of course, with the use beta blockers. The case with severe heart failure, breastfeeding is discouraged because reduce the high metabolic demand and adapted to optimal treatment for mother. Fortunately, most heart failure medication are compatible with breastfeeding. Both warfarin and low molecular weight heparin are considered safe with lactation, and of course, novel anticoagulants are not. How to continue treatment? 4 to 6 months after full recovery, relapse of peripartum cardiomyopathy has been observed after rapid tapering or heart failure therapies. In low ejection fraction after 6 to 12 months, implantation of an ICD and cardiac resynchronization therapy, or when left branch bundle and QRS, it's more 130%. Concealing during the subsequent pregnancy is very important to ensure stability of ejection fraction after at least 3 months of medication, prior to consider if ejection fraction is fully recovered. Few data support the prophylactic use of beta blocker in subsequent pregnancies in recovered ejection fraction. But with recovered left ventricular function, of course, ACE inhibitor, RB, and aldosterone receptor antagonists should be discontinued prior to conception. About 5 or 75% of women with this disease process and have a full or normal ventricular function. But even with normalized ejection fraction, counseling is required. Sudden cardiac death has been reported in low ejection fraction in acute and chronic stage, as well in normalized ejection fraction. Subsequent pregnancies should be discouraged if left ventricular dysfunction after the first pregnancy or ejection fraction is low, about 60%. The contraceptive should be addressed in high-risk women. Progesterone only are considered safe, including the hormonal IU of subdermal implant. Estrogen contains contraceptive should be avoided. In conclusion, peripartum cardiomyopathy should be suspected in a pregnant or postpartum woman with symptoms of heart failure. Echocardiography is safe and should be performed in any suspected case with elevated BNP. Additional of bromocriptine to standard therapy of heart failure immediately after delivery was safe and associated with better outcome. Genetic tests may be considered in peripartum cardiomyopathy, in particular in patients with positive familial history. A better understanding of pathogenic mechanism it's important to development and to development of peripartum cardiomyopathy, to establish new therapies that can improve the outcome for these patients. Thank you for your attention.
Thank you, Dr. Sanila, for the presentation.
Hello everyone, I'm Dr. De La Torre. I am medical resident of surgical pathology in Hospital Clínico San Carlos in Madrid, Spain. First of all, I'd like to thank the organization for inviting me to participate in this third international webinar on gynecology and obstetrics. I'm going to talk about a study we made in our center titled Changes in Cervical Lesions Caused by Human Papillomavirus Infection following the introduction of vaccination. Human papillomavirus (HPV) are members of Papillomaviridae family with over 200 subtypes identified. HPV is the most prevalent sexually transmitted infection worldwide, causing both benign and malignant lesions in men and women. This is why the high prevalence of human papillomavirus infection and its relationship with diseases underscores its relevance for public health. All HPV subtypes are classified based on their association with the malignant transformation of cells in three risk groups: low, indeterminate, and high risk. Therefore, the associated risk of these benign or malignant lesions varies depending on the HPV serotype. There are different risk factors known until now involved in the development of cervical cancer. But between all of them, the persistent infection of HPV virus appears to be the main risk factor. As all of you know, initial infection requires microtrauma of the epithelial basement membrane for the virus to infect the cells. Then the infectious viral particles spread through the epithelium, causing first intraepithelial low-grade lesions, scene 1, which can progress into high-grade lesions, scene 2 and scene 3, and finally to cervical cancer. The progression of high-grade lesions to carcinoma requires the accumulation of additional epigenetic and genetic alterations, a progress that can take 20 to 30 years. Considering the etiopathogenesis and natural history of cervical cancer and its precursor lesions, particularly after the recognition of HPV as a causal agent, there is clear evidence of the prognosis advantage of early diagnosis through the implementation of screening protocols. In Spain, a screening protocol has been followed since 1918, with the primary objective of early detection and treatment of lesions caused by the persistent HPV infection. However, it wasn't until 2018 that the World Health Organization declared cervical cancer as the first eradiable cancer, calling for global implementation of screening and vaccination programs. Implementation of these programs has reduced the incidence and mortality of this infection by 70 to 80%. Here I present you the screening program that we have in Spain, which is a population-based rather than opportunistic. This kind of screening improves the detection capacity of SIN3 lesions and reduces the interval of SIN3 before the next screening test. That is why in Spain, the 60% of cervical carcinomas occurs in women who have either undergone inadequate screening or have been exempted from it. The distribution of human papillomavirus prior to the implementation of vaccine has been extensively studied. According to studies conducted by Bonglio et al. In the year 2000, the prevalence of high-risk HPV was 73.5% in HSIL, 98.3% in squamous carcinoma, and 100% in cases of adenocarcinoma. HPV-16 was the most represented type in all lesions, with the 70.2% of HSIL cases, 73.3% in squamous carcinoma, and 50.6% in adenocarcinomas. But following the introduction of HPV vaccination programs, it was seen that the HPV-16 prevalence increased sharply in more severe lesions, rising from the 28% in normal ASCUS, LCIL, or SIN1 lesions to a 47% in SIN2, HSIL, and 63% in SIN3 or squamous carcinoma. Additionally, types 16, 18, and 45 were found to constitute a higher or equivalent proportion of infections in SIN3 when compared to normal cytology. We designed an observational retrospective study in a single hospital of Madrid, Spain, which took care of 400,000 people. We studied 3 different time periods, 2002 to 2006, before the introduction of the vaccine, 2009 to 2011, shortly after its implementation, and 2020 to 2021, where the vaccine had been implemented for more than 10 years, with a total of 946 biopsies. Our main objective was to analyze HPV-related lesions trends across these 3 time periods, and a secondary objective to compare the main type of virus involved in the high-risk lesions in the first and the last time period, and to compare the mean ages of high-risk HPV-associated lesions in the different time periods. Our inclusive criteria were women with HPV-positive cervical lesions, HPV detected by Genomica, and we excluded men, non-cervical lesions, or HPV-negative biopsies. As our results, with respect to the lesions, we concluded that SIN1 lesions declined from a 61.8% to a 38%. Lesions SIN2 and SIN3 increased from 29.4% to a 59.2%, and squamous cell carcinoma decreased significantly. Lastly, adenocarcinoma remained low. Regarding the results of the serotype evolution, we concluded that HPV-16 and 18 dropped from a 48% to a 24%, other high-risk serotypes increased to a 40%, and indeterminate risk types also rose significantly. Finally, analyzing the ages, we saw that SIN2 and 3 mean age increased from the early 30s to the latest 30s. Squamous cell carcinoma from 29.5 to 54 years, and adenocarcinoma is stable at mid-50s. As our conclusions, we highlighted that it is proven efficacy of current HPV vaccine against several included serotypes. There is a decrease in incidence of squamous cell carcinoma of the uterine cervix in the study population. There is an increase in the mean age at diagnosis. There is an emergent shift of HPV serotype trends, and that there is a rising prevalence of high-risk serotype not covered by the current vaccines. The increase of the premalignant lesions seen 2 and 3 are due to update to improvement of screening criteria and the diagnosis technique used, and the increase in the participation in population screening and detection of lesions before they reach the degree of carcinoma. To conclude, I would like to express my special thanks to my colleagues Dr. Colino and Dr. Fernandez Aceñero, without whom this project would not have been possible. And thank you all very much for your attention.
Hello, my name is Maria Eva Hartus Corona. I'm a midwife and I'm currently working in different health centers in Madrid, Spain. With my colleague Isabel María Gómez Conejo, she's also a midwife and she works in the La Bajón and La Marazuela Health Center in Las Rozas, Madrid, Spain. We've done a research study in vulvar lichen sclerosus. We published it last year in the magazine Matrona Soy of the Spanish Association of Midwives. I'm going to present detection of vulvar lichen sclerosus in the primary care midwife's office, a descriptive study. As we all know, vulvar skin disease is a common reason for consultation. However, fear and cultural taboos lead some women to hide their symptoms. Lichen sclerosus is in the classification of inflammatory vulvar dermatosis. Vulvar lichen sclerosus, VLS, is a chronic inflammatory autoimmune disease of the skin that mainly affects the anogenital area. It is a common pathology, however, it is underdiagnosed and undertreated. Underdiagnosed because patients do not seek medical attention. They are treated by different specialties. Due to the lack of experience, there is a difficulty in detecting the pathology, and some of the women are asymptomatic, and it is undertreated. The etiology, prevalence, and incidence. The etiology is unknown. It is a multifactorial origin including genetic, autoimmune, hormonal, and local antecedents. The exact prevalence of VLS is unknown, and it's more common in female than in male patients. And we know that the incidence in adult women seems to be increasing. Around 54% of the women are postmenopausal, and it is important to know that there is a typical bimodal onset prepubertal children and postmenopausal women. However, there are different research studies. For example, a group in London determined that in their clinic, approximately 20% of the patients developed VLS in their reproductive years. And a group in Beijing found that 75.2% of their sample of 129 women developed VLS during the fertile period. In 2005, Goldstein determined the prevalence of VLS, the histologically proven rate being 1.7% in general gynecological practice, highlighting that 54% of these women were postmenopausal with a mean age around 52.6 years. We also want to talk about the doctoral thesis of the Dr. Lucia Barchin Ortiz in the Gregorio Marañón General University Hospital in Madrid, Spain. She included 227 women, and the mean delay in diagnosis is reported to be around 5.62 years. Around 94.7% of the women presented symptoms, and the most frequent symptoms reported was vulvar pruritus. 54.6% of the cases presented dyspareunia. The mean age at diagnosis was 59.95 years, and the mean age of the patient at the beginning of the symptoms was 53.72 years. Sexual dysfunction was considered important for the patients. In addition, half of them suffered from severe VLS and 5.3% developed vulvar neoplasia. It is important to note that the severity of VLS was graded as age and onset, and delay in diagnosis increased. The most common presenting symptoms of VLS is vulvar pruritus, as we said before, and other symptoms include dyspareunia, dysuria, sexual dysfunction, and genital bleeding. The course is unpredictable, and if left untreated, about half of the patient will lose the structure of the vulva. The labia minora eventually become reabsorbed, the clitoris become entrapped and buried, an atrophic, shiny, and white vulva is revealed, and there is a reduction of the vaginal introitus, vulvar synechia, and bleeding from skin fissures, causing painful areas with secondary infections. For the diagnosis, we have to do a complete anamnesis with all the information from our patients, a clinical examination. Women who present symptoms should be examined by a health professional with experience in vulvar pathology. An importance of vulvar self-examination should be recommended to all the women, and if they see changes in their vulva, they always have to ask. And in some cases, we have to do a biopsy. It is important to note that most cases are diagnosed by dermatologists and gynecologists. However, other specialties as well as nurses are also detecting high percentages of cases. In Spain, as the midwife is a specialist nurse in sexual and reproductive health, we are one of the professionals who potentially detects this pathology more frequently. The diagnosis of VLS is usually clinical, although a confirmation biopsy is recommended in that cases. However, it is generally agreed that suspicious lesions, particularly when they are resistant to the adequate first-line therapy, should always be biopsied. Some authors recommended performing a biopsy whenever possible before starting the treatment, because it is important to note that individuals treated with topical corticoids, the biopsy results may be altered. In most cases, a clinical diagnosis is made, but a biopsy is recommended, especially to exclude neoplasia or vulvar intraepithelial carcinoma. The definitely diagnosed test is a skin biopsy, as we said before, and should always be taken from the most densely weighted area of the vulva. VLS carries the risk of transforming into vulvar intraepithelial neoplasia and vulvar carcinoma, making chronic follow-up and treatment essential. Early detection is important, as squamous cell carcinoma of the vulva is seen up into 3.57% of women with this condition. It is not possible to predict which patients are susceptible, so all should be considered at risk. The longer the symptoms persist and the greater the loss of the vulvar architecture, the higher the risk of developing a cancer. The treatment. There is no definite cure. As we said, it is a chronic disease. As the exact etiopathogenesis remains unknown, the treatment primarily relieves symptoms, reverses signs, and prevents further anatomical changes. All cases, even those that are asymptomatic, should be treated, all of them. Numerous studies have shown that this condition significantly affects the quality of life of the patient. Right now, with my colleague Isabel María Gómez Conejo and with other midwives in Madrid, Spain, we're doing a research study to study how VLS affects the quality of life of patients. And it is important to know that treatments substantially improve this quality of life. The role of the midwife in the detection of vulvar pathology. In Spain, the midwife, as we said before, is a specialized nurse and is recognized both healthcare sectors in primary care and specialized care. Our work has a significant impact on important social domains, such as maternity and comprehensive care throughout women's life cycle, including reproductive health, the climacteric period, and sexuality. At the international level, the midwife is a recognized professional in all healthcare systems of developed countries and is considered an essential figure for the comprehensive healthcare of women throughout their lives. The study aims to demonstrate the importance of the primary care midwife's role in the detection of vulvar pathologies, specifically VLS. In the midwife's office, multiple cases are incidentally detected when patients come for a cytology, pregnancy monitoring, postpartum care, and other reasons. The midwife is the healthcare professional best suited to detect vulvar alteration and in cases of suspected VLS, such as the specific case studied, refer women to the dermatology department for diagnosis. The research objective of the research study, our general objective, it is to determine the proportion of cases with suspected VLS based on the assessment made in the midwife's office and later confirmed by the dermatology department. And the specific objectives are to determine the proportion of vulvar pathology cases, VLS, confirmed by biopsy, to record the most common symptoms in women diagnosed with VLS, to describe the treatment prescribed by dermatology for patients diagnosed with VLS, to specify the most common reason for consultation, and calculate the average frequency of visits for these patients in the midwife office after the VLS diagnosis is established, and to value the preventive work of midwife in the detection of vulvar pathologies. It is a retrospective, descriptive, observational study, and it is a review of the clinical records of women who visited the primary care midwife's office at the La Bajona La Marazuela Health Center in Las Rozas, Madrid, Spain, during the period from June to December 2021. 20,615 women aged 18 years and older at these health centers during the specific dates. The population was patients over 18 years old who visited the midwife's office for the following reasons: cytologies, vaginal swab, and pregnancy and postpartum care. Patients previously diagnosed with vulvar pathology were excluded from the research study. The sample size: all patients who visited the midwives, as we said before, the midwife's office during the period from June to December 2021 were included, and there was a total of 973 patients. The main variables were suspected diagnosis of VLS according to a midwife assessment. VLS often begins as well-defined area around the clitoris, which then progresses to other vulvar areas. In more extensive cases, both the vulva and perineal regions may be affected. Diagnosis of VLS in the dermatology service for patients with suspected diagnosis referred from the midwife's office. The diagnosis of VLS is primarily clinical. A biopsy is only considered necessary if there are diagnostic uncertainties, atypical cases, or suspicious of malignancy, but it is not routinely performed, and diagnosis confirmed by biopsy. Other variables are age, presence of symptoms through interview, as dyspareunia, insomnia, vulvar pruritus, reason of consultations, number of episodes of atrophic lichen sclerosus recorded in the midwife's agenda from June to December 2021, and the number of episodes of dyspareunia recorded in the midwife's agenda. The results of the study were: we had 973 patients. Of them, we referred to dermatology 38, that is 3.9%. Of the 38 women, 29 were diagnosed with VLS, it is around 66.31%, and 9 of them were not diagnosed with VLS, 23.69%. The prevalence of VLS among the total, we had 29 among the total that were 973 patients, that is around 2.98% of the women. Out of the 29 patients diagnosed with VLS, a clinical diagnosis was established in 18 patients, and a biopsy was performed on 11 patients, 37.93%, and the results were positive in 5 patients, 17.24%, and non-specific in 6 patients, 20.6%. Here we have the distribution of VLS patients by age, and the patients diagnosed with VLS had a mean age of 57.79 years, and they are distributed as follows. From 52 to 85 years old, 20 patients, that is around 68.96%, and from 29 To 50 years old, 9 patients. Other results were that from the 29 patients we had, 26 had vulvar pruritus, that is 89.65%, dyspareunia in 15 of them, 51.75%, and insomnia in 26 women, that is around 89.66%. The gold standard for treatment of VLS is ultra-potent topical steroid. The second-line treatment included calcineurin inhibitors, retinoids, and immunosuppressants, and surgery may also be considered. The majority of patients in the Placental study were treated with very high potency topical corticoids, 1 patient with protopic, and 3 patients were not treated because they did not attend their appointment. Of the 38 women with suspected VLS, 16 came for a cytology, 7 for a vaginal swab, 11 due to vulvar pruritus, and 4 during the postpartum visit. This confirms that in most cases it is an incidental finding. As a conclusion, we want to say that among the symptoms and in line with the literature, the most common reported by the study sample is vulvar pruritus in 89.65% of the cases, as we said before. 52% of the patients reported dyspareunia, which aligns with findings from studies that highlight the negative impact of VLS on sexual function. Patients with suspected VLS are often detected initially, with the most common reason being the performance of a cytology. VLS is a chronic condition, as we said before, and it is important to note that the frequency of visit increased once the diagnosis was established. The primary reason for consultations were concern and side effects related to the treatment. After being diagnosed with VLS by the dermatology department, there was an increase in healthcare demand, with an average of 4 visits per patient during the study period. The midwife plays an important role in the early detection of vulvar abnormalities because of their involvement in the examination of women. There is a clear need to improve the training of midwives in vulvar pathology. It is important to note that the low percentage of initial suspicion diagnosed, inappropriate treatments, and delays in diagnosis highlighting the need for the further education and awareness in vulvar pathology. So to reduce the symptoms and lesions, prevent the appearance of irreversible changes and disease progressions, improve the quality of life, and prevent development of vulvar squamous cell carcinoma, an accurate and early diagnosis, appropriate treatment, and lifelong follow-up for these patients are essential. The discrimination women have faced in society has impacted their health. The first statistics on women's health issues were not collected until the early 20th century. Female patients have not received the same level of medical attention. Early diagnosis, appropriate treatment, and lifelong follow-up are essential for these patients. The main limitation of the study is that we only included women who visited El Abajón and La Marazuela Health Center for different reasons. However, the ideal approach would be to study a larger population of women from different health centers. We want to thank Dr. Pablo Lázaro Chaita, Dr. Ricardo Rodríguez Barrientos, and Ms. Luisa María Caballero Ballesteros. Here we have the bibliography. Thank you very much for your attention.
Good morning or good evening to everyone. Warm greetings from Poland. My name is Anna Janowicz-Grelewska and I work as a perinatologist at the Świętokrzyskie Center for Mother and Newborn. I'd like to thank the organizers for the opportunity to speak at this conference and to present a widely recognized topic on fetal growth restriction, different causes, one solution. Can we go beyond that? Considering that we are at the international conference, it's important to note the fetal growth restriction affects 1 in 7 newborns worldwide. According to a definition, fetal growth restriction refers to fetuses that they don't reach their genetically expected growth potential, and the FGR is defined as estimated fetal weight below the 10th percentile. For gestational age within this group, it's essential to distinguish true FGR from the fetuses who are just small for gestational age, SGA, but they are not pathological. Why is the fetal growth restriction an important issue? Because it's associated with a wide range of complications affecting both fetal life and long-term health. Prenatally, it increases the risk of intrauterine hypoxia and fetal death. In the perinatal period, it's linked to hypothermia, hypoglycemia, and metabolic disturbances. Over a lifetime, individuals born with FGR have a higher risk of developing cardiovascular diseases, type 2 diabetes, and neurodevelopmental disorders compared to general population. To make a proper diagnosis of FGR, we need to confirm the date of the last menstrual period and, if it's necessary, adjust it based on estimated date of delivery derived from a first trimester ultrasound scan. If the first trimester ultrasound scan is not available, we can estimate the fetus age based on measurements such as FL, HS, cerebellum, or clavicle length. Once the biometry has been adjusted according to gestational age, FGR can be diagnosed based on the ISUEC guidelines and Delphi consensus criteria, which take into account the parameters such as estimated fetal weight below the 10th percentile, abnormal Doppler findings, and growth trajectory. According to academic classification, we distinguish two main types of fetal growth restriction: asymmetric FGR, which refers to proportionally small fetuses with growth restriction beginning early in pregnancy, and asymmetric FGR, typically appearing in the third trimester, characterized by reduced abdominal circumference due to decreased liver size. The differentiation between symmetric and asymmetric FGR is based on the timing of its onset and abnormalities in Doppler flow measurements. Here we have a photo of a boy born at 33 weeks of gestation with relatively mild hypotrophy. What are the causes of FGR? So again, from an academic perspective, the causes of FGR can be classified into maternal, placental, and fetal placental factors, with multiple pregnancy considered as a separate category. Maternal causes of FGR are including chronic conditions such as hypertension or diabetes. And in developed countries, additional contributing factors may include substance abuse, maternal obesity, and smoking. And in developing countries, the main issues are low socioeconomic status and maternal undernutrition. Among the fetal causes of fetal growth restriction, which show a certain consistency worldwide, are genetic abnormalities, which may vary in prevalence across the regions, of course, and infections, primarily viral and parasitic, such as toxoplasmosis and CMV infections. Here we have a graphical presentation based on UNICEF data from 2 years ago showing the prevalence of low birth weight infants. And the main key observations are that the highest percentage of low birth weight newborns, reaching up to 30%, is in South Asia. Saharan Africa has also high percentage of small newborns, exceeding 15%. Latin America rates ranging between 5 and 10%, and in Europe and in the North America, they have the lowest rates, generally below 5%. And according to World Health Organization, these data highlight the urgent need to focus on health initiatives of improving maternal health and access to prenatal care in regions with a high prevalence of fetal growth restrictions. So the next question is how to make a diagnosis. So it involves a fetal biometry and estimated fetal weight plotted on growth charts. Fundal height may support assessment, but it's unreliable in cases like multiple pregnancy or fibroids. Fetal well-being is evaluated via Dopplers of umbilical artery, MCA, and ductus venosus, and supported by CTG. In the diagnostic workup of fetal growth restriction, amniocentesis is also often performed to assess the fetal karyotype or confirm intrauterine infection. In the assessment of placental function, measurements of biochemical markers such as PLGF and SLIT are used, which are also helpful in diagnosis of preeclampsia, a condition that is often accompanied by FGR. Here we have scans showing growth curves, a fetus with a weight below the first percentile, and growth trajectory of a fetus with a weight below the 7th percentile. Management. Management is a challenge. It involves close monitoring, serial ultrasound and Doppler examinations, hospitalization in severe cases, and corticosteroid therapy to promote fetal length maturation when the preterm delivery is anticipated. What we need to remember is that the FGR is a serious condition with no effective treatment, so delivery remains the only solution. And the challenge is timing. Choosing between iatrogenic preterm birth and the risk of intrauterine fetal death. In conclusion, I'd like to point out that FGR is a complication with both short and long-term consequences. Early detection and regular monitoring of pregnant patients are essential in the managing of pregnancies affected by FGR. Overall, I'd like to return to the causes of fetal growth restriction and draw attention to the current global context. As doctors, we cannot ignore the global crisis shaping maternal health and fetal health, from conflicts and poverty to climate-driven migration. There are not just background conditions, there are real stressors affecting real pregnancies. So let us remember our role goes beyond medicine. We have the voice and the responsibility to help build a safer, more compassionate world. Thank you for your attention.
Good evening, everyone. My name is Indumati Shanmugam. I am a registrar in obstetrics and gynecology, currently working at Northeast and Hartlepool NHS Foundation Trust in the United Kingdom. First of all, I'd like to sincerely thank you for this great opportunity to be part of this esteemed international conference. The title of my presentation is Hypothyroidism, a Potential Threat to Ovaries. This is a rare and interesting case report of an adolescent girl who presented with bilateral ovarian cyst and ovarian torsion, secondary to previously undiagnosed primary hypothyroidism. As we know, Ovarian cysts are common gynecological condition with a wide range of etiologies, including functional cyst, benign, malignant cyst, endometriotic cyst, and cyst due to endocrine function. This case emphasizes the critical importance of considering endocrine disorders, particularly hypothyroidism, in the holistic assessment and management of ovarian torsion, especially in young adolescent patients. So the clinical details, including photos and radiological imaging, have been added after informed consent from the patient. Before I begin, this is the brief overview of what I'll be presenting today. So I'll start with the patient background, outlining the clinical presentation, then move on to the diagnosis, including investigations and key findings. Next, I'll discuss the management approach we taken, and this will be followed by outcome and follow-up of the patient. I'll then move on to the discussion, highlighting the relevant literature and learning points. Finally, I'll conclude my presentation with the takeaway message from this case. So let's begin. Our patient is a 16-year-old adolescent girl with a BMI of 27 who attained menarche at the age of 12. So since menarche, she reported irregular menstrual cycles occurring approximately once in every 3 months. She also had a past history of intermittent lower abdominal pain, for which she had visited the primary care multiple times, but there was no definitive diagnosis was made. So she presented with us with a acute onset severe lower abdominal pain and vomiting. On clinical examination, her vital signs were stable. However, there was a diffuse lower abdominal tenderness and a palpable abdominal mass approximately corresponding to 24 weeks gestational size. So the pregnancy was ruled out and we ordered an imaging ultrasound abdomen and pelvis with a Doppler. So the imaging showed bilateral ovarian cyst with a torsion, and we have ordered the preoperative blood investigations as well. The preoperative blood investigations were sent that revealed primary hypothyroidism. So this is the radiological ultrasound imaging of bilateral ovarian cyst. The ovaries were enlarged with a multiloculated ovarian cyst. So the ultrasound report showed bilateral enlarged ovaries with a multiple anechoic cyst, possibility of right tubo-ovarian torsion, and there was a minimal free fluid noted in pouch of Douglas as well. So given the patient's age, symptoms of acute abdominal pain, and a large abdominal mass, several differential diagnoses were considered at the time of presentation, including pregnancy. We have ruled out that, and hydatidiform mole, endometriotic cyst, and other non-gynecological causes. However, based on the clinical evaluation, ultrasound imaging and Doppler, and the hormonal investigation, the final diagnosis was made as an ovarian torsion with a bilateral ovarian cyst and hypothyroidism. So, the patient and her parents were explained the need for surgical intervention due to the acute presentation, torsion, and large ovarian cyst. So, a detailed discussion was held regarding the options of laparotomy versus laparoscopy, and after considering the risks and benefits, the parents decided to proceed with laparotomy. So, the preoperative investigations, as I already mentioned, revealed anemia, and the thyroid function test revealed diagnosis of hypothyroidism. So intraoperatively, there was a 50 ml of hemoperitoneum, and the left ovary was enlarged with a multiloculated ovarian cyst approximately 10 cm in size with a one twist torsion and the right ovary also was enlarged with a multiloculated 8 centimeter size cyst with a 2-twist torsion. And both the ovaries and fallopian tubes were edematous. So we proceeded with the laparotomy, and the procedure involved was detorsion, and we did a cystectomy as well, and oophoropexy to prevent any further recurrence of torsion. And post-operatively, the thyroxine replacement was initiated to manage the patient's hypothyroidism. So this is the intraoperative imaging of an ovarian cyst. On follow-up, her blood report showed significant improvement. The anemia has been corrected. The hemoglobin has improved from 8.5 to 10.4, and her TSH level, which was previously more than 100, has come down to 6.17. And we did imaging as well. The imaging revealed that the ovaries have returned to normal size. More importantly, her symptoms, irregular menstrual cycles, have regularized. This is an image of an ovary before the procedure, which shows enlarged ovaries with a cyst. This is the image post-operatively 3 months after the procedure, which revealed normal ovaries. And the histopathology has been reported as benign serous cystadenofibroma and thecal lutein cyst, which is consistent with hypothyroidism. So coming to the discussion, there are several theories that explain how ovarian cyst can develop in hypothyroidism. So the first of all, the structural similarity between TSH and FSH receptors. So the extremely high concentration of TSH in hypothyroidism may be sufficient to cause activation of the FSH receptors. And the second theory was the TSH may sensitize the ovaries to gonadotrophin stimulation by stimulating the nuclear thyroid receptors in the granulosa cells, thereby increasing the ovarian hyperstimulation. That's also known as von Wijk and Krumbach syndrome. And the third possible mechanism has been hypothesized to be an FSHR mutations permitting over-amplifying the effect of HCG or TSH on the ovarian follicles that also can cause ovarian hyperstimulation. So from literature, Nandi Monish D. Pediatrics has reported a rare complication of primary hypothyroidism with ovarian cyst and torsion requiring oophorectomy. Whereas in this case, we managed to conserve the ovary. We managed to proceed with only cystectomy and oophoropexy. So the main takeaway from this is hypothyroidism is an overlooked cause of an ovarian hyperstimulation. So as we all know, unlike an usual case, this case is a rare case of an primary hypothyroidism presenting as an acute ovarian torsion demanding surgical intervention. So the main takeaway here is hypothyroidism is an overlooked cause of an ovarian cyst, and it is crucial to evaluate primary hypothyroidism in adolescent girls with a bilateral ovarian cyst to provide not only the holistic care but also to prevent the recurrences and to prevent the complications including ovarian torsion and to avoid the surgical intervention as well. Thank you.
Hello, my name is Liliana Lopez. I am currently a medical resident in human reproductive biology in Mexico. Today, at the third international webinar on gynecology and obstetrics, I will be discussing a case of placental site trophoblastic tumor that we had at the Hospital de la Mujer in Ciudad Juárez, Chihuahua, Mexico. Let's begin. Gestational trophoblastic disease includes various disorders of cellular proliferation, classified as follows. Pre-malignant pathology, complete and partial hydatidiform mole. Malignant pathology, gestational trophoblastic neoplasia, invasive mole, choriocarcinoma, placental bed tumor, and epithelioid trophoblastic tumor was recognized as a neoplasm by the World Health Organization in 1983. It is a rare and malignant disease with an incidence ranging from 1 in 50,000 to 100,000 pregnancies. As of 2016, 300 cases had been reported. Risk factors: pregnancy at extreme ages, very young or older, and prior pregnancy history. Clinical case: a 23-year-old woman with a history of 3 pregnancies, 1 delivery, 1 abortion, and 1 molar pregnancy. She had 2 previous miscarriages, the most recent one 2 months ago. She presented with vaginal bleeding for 25 days. Initial ultrasound, an irregular image in the uterine fundus measuring 17.7 mm. Laboratory tests, HCG of 80,123 MUI/mL and hemoglobin of 5.8 gdl. Follow-up ultrasound, an irregular image in the posterior uterine aspect measuring 18 x 17 mm with intense color Doppler flow. The repeated presence of trophoblastic and decidual tissue in both studies suggests the retention of pregnancy products. The hyalinization observed in the second analysis indicates that this tissue remained in the uterus for a prolonged period, leading to chronic degenerative changes. The hemorrhagic infarction suggests that the placental tissue suffered severe ischemia with vascular damage, which is common in non-viable pregnancies or when there is implantation failure. The 3-week interval between both studies indicates that the tissue remained in the uterine cavity longer than expected for natural resolution. The patient presented with severe anemia requiring a blood transfusion. There was also mild proteinuria and ketonuria, which could be related to a state of metabolic stress caused by the bleeding, with no other abnormalities detected in other systems. Due to the elevated levels of human chorionic gonadotropin, HCG, and the ultrasound findings that did not correspond with a normal pregnancy, serial HCG measurements were taken. There was a 200% increase in just 5 days, followed by a decrease starting on April 4th, the date on which surgery was performed. The abdominal and pelvic CT scans, both plain and contrast enhanced, showed that the uterus had contrast enhancement in the arterial phase, primarily in the endometrium and adjacent myometrial portions. This enhancement continued in the venous phase of the study. Treatment: total abdominal hysterectomy. Upon examination of the surgical specimen, a solid lesion approximately 2 cm in size was found within the uterine serosa, consisting of spongy tissue that was intimately adhered to the endometrium. The histopathological report confirmed a placental bed trophoblastic tumor with focal invasion into the myometrium. The patient was referred to the oncology department for follow-up and HCG quantification. Based on the histopathological report, the diagnosis of placental bed trophoblastic tumor with focal invasion into the myometrium was established. A second histopathological report confirmed the presence of polygonal and pleomorphic tumor cells with abundant cytoplasm invading the myometrium. Immunohistochemical staining was positive for HCG, supporting the diagnosis. Placental bed trophoblastic tumor is a malignant proliferation of intermediate trophoblast at the site of placental implantation. The age of affected patients ranges from 20 to 63 years, with a mean age of 31 years. The interval between the previous pregnancy and the onset of the tumor can vary from a few months to 20 years, with the median latency being 12 to 18 months after a full-term delivery. The most common symptoms are vaginal bleeding with uterine enlargement followed by amenorrhea and abdominal pain. A mild to moderate elevation in serum HCG is seen in about 80% of cases, which can be used as a diagnostic tool. Recurrence or metastasis occurs in 25 to 30% of patients after surgery. Diagnosis requires HCG determination, radiological and ultrasonographic examination, and a histopathological study with immunohistochemicals. 3 types of ultrasound presentations of placental bed trophoblastic tumor have been described. Type 1, description, heterogeneous solid mass in the uterine cavity, color, Doppler, minimal to moderate vascularization, clinical interpretation, may be confused with retained placental tissue or an endometrial polyp. Limited vascularization may make it harder to distinguish from benign lesions. The intracavitary location is less typical for PSTT, which tends to be deeper, so this may represent an early stage or an unusual variant. Type 2, description, heterogeneous solid mass within the myometrium, color Doppler, minimal to high vascularization. Clinical interpretation, this is the more typical presentation for PSTT. Myometrial involvement indicates more infiltrative behavior, which is characteristic of this entity. The variable vascularization reflects the tumor's angiogenic activity, with high vascularization potentially indicating higher aggressiveness. It should be differentiated from atypical fibroids, adenomyomas, or invasive gestational neoplasms. Type 3, description, cystic lesions within the myometrium, color Doppler, high vascularization. Clinical interpretation, this is the least common but the most striking presentation. Cystic lesions may suggest tumor necrosis or degenerative changes. Intense vascularization helps differentiate it from benign cystic lesions like adenomyomas or cystic fibroids. This variant may be misinterpreted as an intramyometrial ectopic pregnancy. Ultrasound, computed tomography, and magnetic resonance imaging are commonly used to assess the extent of the disease. The most common sites of metastasis are the lungs and vagina. For regional lymph nodes, pelvic lymphadenectomy is recommended in conjunction with hysterectomy if adverse risk factors are present. Oncological follow-up is required. Conclusions. Diagnosis is complex due to the lack of sensitive and specific tumor markers. The main clinical indicators are vaginal bleeding and elevated HCG levels. Transvaginal ultrasound with color Doppler is highly useful for suspicion. The primary treatment for non-metastatic tumors is hysterectomy and bilateral salpingectomy, with pelvic lymphadenectomy remaining a topic of discussion. All these cases should be managed at centers with clinical expertise and specialized histopathology. Thank you.
Topic over here. The objective of the research is apply feature selections to reduce data dimensionality and select optimal features. So most of them are from medicinal background. Can ask me a question saying that how can you combine, or how can you merge the mathematical concept into the medicinal field? This is what the study makes a sense. So we have taken a multilinear regression equations and we are just stipulating into technically speaking technically we are implementing by having few parameters of PCOS, polycystic ovary syndrome. So to investigate the performance of the model with the existing models, we have done with the variance test, and to improve the provider model explanation to ensure the efficiency and effectiveness and the trust. So the methodology goes like this. We have collected the data through online source itself. So from kegel.com, we have selected the data, and further we have just taken the data processing and feature selections, what are all the parameters needs to be considered for the study, and what are all the parameters that we can just leave it. It is not negligible, but the main role or the key role of the parameters that we have considered for the study. And the whatever the data set we have considered, we have divided into two different parts. One is training data set and another one is testing data set. Based on this, we have built with the multilinear regression model. Then we have performance with the evaluation test. So first, let me just discuss about the materials and methods. What are all the materials and the methods that we have used? So it is, as I have already told you, that we have taken the data from the kegel.com. This open source data set is nearly having 541 patients data, and we have collected from 10 different hospitals across Kerala, and it is speaks about nearly 41 number of parameters. There are 41 parameters are there. We have hardly used single digits or 9 to 10 parameters, and we have improvised the model efficiency. So the data set description is, and the parameters that we have considered is, as we know that if someone is suffering from PCOS, make sure that the key points which usually come to even non-technical background layman people is saying that menstruational cycle length, AMH level, weight gain, hair growth, fast food consumptions, darkening of skin, pimples, follicle counts, insulin level. So by having these major parameters, we have come out with a beautiful model. And here you could see the correlation matrix. The correlation is nothing but the relationship checks between one parameter to another parameter. So how much of strong relationship that each of the parameter that will be showcasing here. So you could observe here 57% of the correlation is happening between insulin and as well as the follicle numbers in the right section. And meanwhile, you can also see over here only 29%. Even you could see that just 12% between the cycles and the pimples. So that we can conclude that there is no such kind of relationship between having a pimples on your skin tones and as well as the periods that you are getting it. So that based on these parameters, we have taken the study ahead. And as we know that it is a multilinear regression. What is multilinear regression model? If I have only one single parameter and one constant variable, then we call it as it is a linear regression model. For example, a straight line. So if it is a multilinear regression model, in the sense we have more than one parameters along with their coefficients, along with the epsilon. Epsilon is says that is a simple and minimal error, also call it as a constant, that we can just neglect it off. So here y is the dependent variable. Y is totally depending upon the parameters. As I have told you that here I have considered these many parameters, which is almost having 9 parameters. If you include follicle count left and follicle count right, then it becomes 10 parameters in count. So those parameters I have expressed in the form of x1, x2, x3 goes on till x10. And B naught is the intercept. What is B naught is the intercept? When all these parameters show some zero values, then what could be the intercept value? That is for a mathematical calculation that we have kept it here. And from beta 1 till beta 10, it shows that is a corresponding coefficients of x1, x2, x3. So now we have considered the data set of 541 patients. We have divided the data set into 80:20 ratio. I mean to say that 80% of the data we have taken for the training the model, and the remaining 20% of the data we have taken it for the testing. So when we taken the sample length, if it is a 80% of the data, in the sense I have received nearly 432 cases. Out of 432 cases, I have just calculated what is its mean, what's its standard deviation, and what's its variance. So you could see that here I have make a actual data versus predicted data. So actual data mean and the predicted data mean, if you look at into that, it shows almost 0.34 and 0.34. That shows that this model is able to capture almost the actual trend. And when it comes to standard deviation, it is 0.47 and 0.44, and variance is 0.22 and 0.19. And testing period, of course, as of I've told you, that 20% of the data has been included for the testing. That is nearly 109 patient cases I have kept it for testing data. This is, I can say that this is a prediction. So training period is nothing but the comparison, training the model, and testing model is nothing but forecasting or prediction of the model. So even for the 109 patients, prediction have come around, the mean value is 0.29 and predicted mean is 0.26. And the standard deviation is 0.46 and 0.42 when it case of predicted data. And variance is 0.21 and 0.18. So how I'm going to tell you, or how I'm going to express the model evaluation, is because of the mean squared error. So while training will take out the error, and even while texting will take out the error. So for the training period is almost negligible value, that is 0.03 is the training period efficiency, and 0.04 after that it's only 4% of negligency we can accept it. The model is showing 4% of variations, and for the training period it showing only 3% of the variance. So model efficiency I have calculated here by using variance test. That means that 1 minus predicted data variance divided by actual data variance, and when we just do this mathematical calculation, we can see to it. For the training efficiency, I could achieve 86%. You can ask me over here. Here root mean square value is showing only 3% and 4% for the testing period data. And when it comes to here model efficiency, when you take the variance test, it exactly gives you how much efficient your model is. So for the training model efficiency, it comes around 86.36%. And testing model efficiency, I have received nearly 86%. So that model evaluation with the correlation analysis, I can check it over here. So when I consider actual data with actual data, of course, it should be 100%. And actual data with the predicted data, it is 93%. And the error value is minus 0.07. And predicted data I have taken with the actual data 93%. And of course, root mean square error value or mean square error value per point, it giving you minus 0.07. And for the predicted data, it is giving with the predicted data, of course, 2%. There will not be a strong correlation. And actually speaking, there should not be a correlation or relationship between the mean squared error with respect to actual data and predicted data. By using actual data and predicted data, we were going to calculate the standard error so that there is no relationship among themselves. Among themselves in the sense actual data, between actual data and mean squared error. And same kind of correlation study have been taken place for even testing data set. So for the predicted and actual, it is nearly covering 91% of the efficiency. And here is the visual presentation. You can observe over here. I have considered this is for the training data set, and I have taken the interval up to 10. So you could see here the actual is the one is presented in blue color, and the predicted one is almost the red color. If you look at into this plot, you can see to it there is no much difference between actual versus predicted PCS values for the training data set. Even for the testing data set also you could observe, since here the graph is more visible neatly, because as the testing period or the testing number of data sets that I have considered is very less, only 20% according to standard norms. We have to keep 80% for training and 20% for the testing. So this is also here also you can see to it, whenever the blue line which reaches 1, and even the red line is also reaching almost 1. So why it is only for 1? In the sense, I'm just taking, if patient is suffering from PCOS, then it reaches 1. If patient, based on these parameters, if patient is not suffering of PCOS, then the value would be always 0. So there is no fluctuation in between. So the conclusion is this: the research highlights the significant role in selecting health indicators in predicting PCOS. And these values, even we have taken for the testing and we have checked with the lab, it is almost matching nearly 86 to 90% of the result. I mean to say that the clinical result is matching with the mathematical results. So that is the model effectiveness, which can employ linear regression model efficiency. Linear in the sense, make sure that it should be multilinear regression model, and it providing a valuable insights into the importance of each factor in predicting PCOS. And when it comes to statistical evaluation, it gives you a proper accuracy, reliability, and which can also capture clinical implications. And what could be my future directions is nothing but we can check out with the external validity by incorporating more number of parameters. If we incorporate more number of parameters, how model is going to behave, so that and all is under processing, those things are under future directions. I'm very happy to share this study with all of you, and I'm very thankful to the team, those who have given me this beautiful opportunity to me. If you have any doubts, the forum is open for any queries, please.